Hello and welcome back to another episode of the EP Growth Podcast. I'm your host, Ryan McCarthy, the director at Hunter Rehab and Health, and I'm joined by a very special guest today. I'm joined by Alana Roberts, registered psychologist with over 15 years experience and founder of Sana Psychology and Avenue Coaching and Training. How you going, Alana?
I'm great, Ryan. Thank you for having me.
No, my absolute pleasure. Very excited to get you on board. First registered psychologist on the podcast. So
that's a privilege.
No, I think it'll provide so much value to the listeners today to get an insight into your world and everything that happens, from a psychologist point of view. But to get us started, why don't you just take us back to the very beginning? Tell us why you got started in psychology, how you got started, and your experience so far.
Yeah, okay. But, if we go all the way back to school, it's a funny one. I think I just got to the end of year 12 and was like, oh my goodness, what am I going to do? I'm not really sure. And funnily, I don't really know what made me think of it. I remember deciding in a science class, though, so it must have been something brain biology or something, related to that. But I thought I'd like to do neuropsychology, which is, the assessment of brain injury. And those sorts of things. And so that's why I applied to the degree. Once I was in the degree, I think I saw there was much more to it than that. But I guess I was actually not particularly attracted to clinical work, which is kind of funny given that I now predominantly work in the clinical space. But I thought I wanted to do neuropsychology. I was young and didn't want to go to Wollongong, which was the only place where they ran the neuropsychology master's program. So at the end of our 4 years, we either sort of have to do something to get accredited at the end and you can do masters or otherwise. And I didn't want to move to Wollongong. So I was tossing up between organizational psychology and more counselling sort of psychology work, and just happened to meet someone at a careers fair from an occupational rehab provider. And I thought, this is interesting. It's sort of, you get to use clinical knowledge and clinical skills, to do rapport building and rehab counselling and things. But you're not working purely in treatment and you're sort of doing stuff with organisations as well. So that sort of piqued my interest and that's where I went after university. I don't know if you want me to keep going there, but basically I then worked just as a rehab consultant for a couple of years before deciding if I wanted to then become a registered psychologist. So after a couple of years, I decided I did. After actually attending a therapy appointment with a family member who was too nervous to go by themselves, I went as their support person and I watched the psychologist in action and thought, this doesn't seem so scary. Maybe I could do this. So then started my internship. And I guess since that time, I've bounced back and forward between occupational rehabilitation psychology and clinical practice sort of thing in a private practice sort of setting. So I haven't done hospital work or anything like that, always just sort of treatment under Medicare or workers' compensation in private work or occupational rehab. And they both offer really different, some similar things, but really different sort of things at different points in my life that I've really enjoyed. So
Excellent.
That's me.
Do you think you would have went down that avenue if you didn't attend that appointment with your friend or family member?
Probably not. No, in my head, clinical psychology seemed scary for some reason, the level of responsibility that I felt you had to hold. And I think particularly when I was at university, I sort of had the picture that psychology was all about like working in, in a health setting, but in like the acute mental health services. So with people who were maybe experiencing psychosis or severe, suicidal ideation, and that side of things hadn't appealed to me. I don't think I'd really understood, even in the health system, there's oncology care psychology, there's all different fields. I had no idea about any of that at that time. And I just, in my mind, clinical counselling psychology in private practice was sort of tied up with that acute picture in my mind. So it was really quite wrong. Counselling in private practice is very different to that. Sometimes it is, acute, but often it's not as well. So.
Yeah, great. Excellent to know. So tell us just a little bit more about, I guess, what it takes to become a psychologist. It seems a little bit confusing from even my perspective in terms of what degrees, and then you have to do another degree, then supervision, or tell us just the process that's involved.
Yeah. So for anyone, aiming to get in at the moment, I would say I'm probably not totally on top of the degree structures, that you can do. I know when I went through about 18 years ago, I think it was, you do an undergraduate degree, but there's all these different pathways. So I did like a Bachelor of Psychology, and it had a guaranteed honours year. I don't believe they do that in many places anymore, if any. But we used to have people sort of who could also join the courses doing a Bachelor of Science or a Bachelor of Arts, and then they would compete for that honours year. My understanding now is, I don't know if the arts and science pathways are there. There's definitely that psychology sort of degree pathway, but my understanding is now they sort of do the 3 first years, and then the 4th year can vary. So for some students, they will compete and get into the honours year. And for others, they'll have to do a graduate certificate or a graduate diploma or something like that as their 4th year. And this is the bit where I'm not, I say, 100% up on it, because it's all the changes have come in after my time. But for us anyway, it used to be that the honours pathway was the only one where you could then go on to become registered.
Right.
A graduate certificate or a graduate diploma might allow you to practice in, maybe like case management roles and things like that, but not therapeutic kind of registered with AHPRA treatment sort of roles.
Yes.
And so then once you get through the 4th year, there's then a couple of different pathways about registration. So I did the 4 plus.
So what are you called after the fourth year? What type of psychologist are you?
You're not a psychologist.
Oh, you're not.
So
Okay.
psychology is a restricted term, and you're not allowed to call yourself that until you've got your, registration with AHPRA, even as an intern.
Okay.
When the couple of years where I did occupational rehab before doing my registration, I was a rehabilitation consultant. So, and then, Bachelor of Psychology in your letters under the name, but not actually calling myself a psychologist or doing, therapeutic work. So you sort of, there's options even within the degree, and you have to be, within a certain percent that do a certain pathway in the 4th year to be able to take the next step. And then you've got, I believe it's 3 options at the moment. When I did it was only 2, but there's internship and masters. And so masters is an additional 2 years at university. You do clinical placement during that time and probably get exposure to a wide range of things and professions. But when I went through, they were accepting about 10 people out of our cohort into masters, and you had to get a first class honours and have been doing like some sort of counselling skills experience generally. So most people who were accepted sort of had gone away, done a bit of counselling work, or they'd been doing lifeline counselling through their degree in order to compete to get into the masters. So I decided not to attempt to get some masters because I was already ambivalent about clinical work anyway, and that's the only clinical masters that was available at Newcastle Uni when I was there. So I took my time to, figure it out. But yeah, now there's the internship pathway. I believe there's an option for a 5+1 and a 4+2. So I did the 4+2, which is 4 years at university and a 2-year internship. The Psychology Board, I believe, is in the process of retiring that pathway, and it will move to a 5-year degree with a 1-year internship. But that's the one that I don't know a lot about. It might be available now. I'm not quite sure of the specifics on that. But essentially, there's internship or masters. And in the internship pathway, look, back when I went through, it was quite easy to get internships, and they didn't have to probably have as much clinical exposure as they probably should have. And so they've tightened up the registration requirements over time. So now during that internship, you will be required to show competency in a varying degree of areas, sort of things. So children work and, counselling work and other things. You sort of can't get it just working in a case management capacity or something like that, like you used to. So
yeah,
probably
okay,
a good thing, but yeah.
So then at the 6 years, that's when you register with AHPRA and you're a psychologist?
Yeah. So if you do the master's or internship, I think you can register as an intern psychologist, then they're monitoring your internship and you can call yourself an intern. But yeah, at the end of the 6 years is when you can actually claim that sort of title of psychologist. And
Yes.
for those of us who do the internship pathway, we're either called just a psychologist or a registered psychologist. And those of us who do the master's program are called a clinical psychologist.
Okay. Yep. Great. That's great understanding. Good to know. And then once you become a psychologist, what ongoing training or requirements are there to remain a psychologist each year?
Yeah, so similar to a lot of other allied health professionals, we've got to do professional development hours every year.
Yep.
And they include not just attending courses and new learning and reading and things. We also have to do supervision. So that sort of clinical supervision, debriefing, discussing of cases and those sorts of things has to form a percentage of our hours sort of things.
So you need to be the supervisor or you need to receive supervision?
Yeah, so you can provide supervision and that will count towards some of those other hours, but the receiving and discussing of your cases has to form a certain percentage of your supervision.
Yeah.
So you have to discuss your work.
Okay. How do you go about finding someone to do that? You reach out to a senior so I can ask if they'd supervise you?
That's right. So
Yep.
it's sort of you might reach out to someone who's got a specialty in something that you're interested in. So, after doing EMDR training, I did some sort of supervision for 6 months with someone who was had been practicing for a number of years in EMDR so that I could bring specifically those sort of trauma-focused therapy cases. And so this is what happened when we tried to process this trauma, can you give me advice or input how I might do that differently? So you can sort of align it with a clinical skill that they have.
Yes.
Or you might, like a philosophy or something. So there'll be different therapists in different therapy types, if that makes sense. So you might get a schema-focused supervisor or an ACT-focused supervisor. And other times you do peer supervision as well. So you might have people that you've worked with before or, have admired professionally and form a group where you all present cases and everyone sort of provides feedback and those sorts of things. So
Okay. Yeah, excellent. Great to know. So can you tell me, like, from a treating practitioner point of view, I think we find, especially within our local community, I think it's maybe statewide or nationwide, why it's very rare to see psychologists working within workers' comp. It's very hard to find one that will accept workers' comp referrals.
Yes.
Can you give us an insight as to why that is the case?
Look, I can only give you an insight from my exposure, and I don't know if this is representative of everyone, but I think there's a couple of things. Back 15, 20 years ago, I stopped doing, after my first rehab job and I went out in clinical practice, after a year or two, I stopped taking workers' comp referrals because I was really burned out for dealing with how adversarial that system was at that point in time.
Yes.
I don't think it's quite as bad now. I think it's come a long way and it's not nearly adversarial, but I think there's a lot of psychologists who are 40 plus who've heard of how adversarial that system is. And so they're not so interested because there's so much work for psychologists at the moment. You might have heard, we're in a workforce sort of shortage situation. There's not enough psychologists to fill the jobs that there are there. So they have their pick of doing NDIS, work under Medicare, private treatment and workers' comp. So if you work in Medicare, the referral comes in from the doctor, and you're given 6 sessions or whatever, you liaise only with the doctor, and you just, work with the client's needs. And there's no extra layer of pressure around a goal of an external system or party. The workers' comp has the, return to work focus, which of course is good because we all know there's better mental health outcomes for people who return to work. But that sort of push and pull of people questioning your treatment and declining plans and sending you off for IPC reviews if they think it's gone for too long, I think a lot of them just want to avoid it.
Yes.
I also think traditionally the rate in workers' comp has been a little bit lower than a lot of clinical psychologists can charge in private practice. So the Medicare system currently has a 2-tier system where registered psychologists get rebated less for the hour of clinical work than a clinical psychologist does, or the hour of therapy that they do. So I think clinical psychologists in particular would be taking a pay cut normally for the hour to do work that has more paperwork, more administrative duties, more like different pressures. So I think that's probably the main reason. There's a lack of understanding about how the system works. And also, I guess, our training is very much be led by your client. You don't tell your client what to do. It's, it's up to them and their decision making. And I think there's a little bit of discomfort in workers' comp work because you're asked, is this person fit? What's the, so you're sort of having to do that. And confidentiality is really strict for psychologists. I listened to an episode by a legal practitioner who sort of has worked with AHPRA, and he said, you've got the most strict ethical code of any health profession, even more so than medical professionals, was his opinion.
Wow.
And so we have it drilled into us across our degree and all through, our internship or masters about confidentiality. And so it's really uncomfortable for psychologists to sort of write a report about your client to an insurer and be asked questions that the client might not want you to answer.
Yes.
Or, and not because, or it can be very intrusive. I frequently get requests for my whole clinical file and notes from insurers. And, there's information about people's childhood and things in there that gives me context to help support them, but is a huge invasion of their privacy to release that. So I think all those little conflicts around lower rate, more people that they've got to liaise with, more administration, any adversarialness, and just those privacy confidentiality grey zone that comes with the workers' comp process, I think dissuades a lot of people from getting involved.
Yeah, that makes perfect sense. But obviously, more recently, you've over the last 5-10 years, you've worked a fair bit in this space, and been one of the rare people in Newcastle that takes on these clients. So I think you've been much appreciated by everyone in that scheme.
Thank
So
you.
what type of common presentations did you see? When you're working with workers' compensation clients, what were the common ones?
So in my last occupational rehab job, I did a lot with a company that worked a lot with emergency services workers, so PTSD predominantly in police, fireys and AMBOs and things. And I guess seeing, being on the other side as the rehab consultant, trying to get people treatment and seeing how little was available was, frustrating for me as well at times. And so when I decided with my business partner, Davinia, to go back into sort of the private practice treatment space, we said, what, let's sort of predominantly see work-related injury. Let's be, a place for that, because we understand the way the system works. We're not scared off by it because we've worked in it, in different capacities. So the most common work-related injuries that we see are post-traumatic stress disorder, major depressive disorder, and adjustment disorders predominantly. A lot of you might see a referral from a general practitioner with a broad kind of category of anxiety, but it's not that common for someone in the workers' comp space to actually meet criteria for an anxiety disorder on its own. So something like generalized anxiety disorder or OCD are not often work-related conditions. They can be in some circumstances, but more commonly claims for bullying and, burnout style work pressure is often sort of considered to be an adjustment disorder. People who experience trauma at work, or what we call vicarious trauma, where they've exposed to the trauma of other people. So emergency services workers, people who work at DCJ and those hospital workers, those sorts of things. We'll see sometimes like a complex post-traumatic stress disorder that develops over a number of years in response to that build-up of trauma over time.
Yeah. Okay. Well, it seems like, PTSD is very common workplace injury. It's something that we see as exercise physiologists a lot, and it might be a bit of a broad question for yourself, as everyone is individualized, but what would a treatment plan look like for PTSD from a psychologist's point of view? Like I've never sat in on one of those consultations before. Like what are your strategies? How do you address PTSD?
It? Yeah. And look, it's going to be, as you say, it's going to be different for every client and different depending on the practitioner. I can only speak to how I practice and the things that I do, but there's various trauma-focused therapies, so you don't have to do one particular style of therapy for that.
Yeah.
But I guess, the thing with PTSD is it's probably going to take a bit longer to treat than some of the other conditions. We see a lot of symptoms that are common across most mood disorders, which might be a reduction in appetite and sleep disturbance and sort of feelings of anxiety, the stress response going off, those sorts of things. And so the treatment for them will be similar across all of those conditions because we're really treating the symptoms, not the diagnosis, if that makes sense. And the brain systems involved in a lot of those conditions are, they're not discrete and separate. Someone with depression doesn't have one section of their brain doing something and someone with anxiety has another.
Yes.
They're both, come down to the same sort of systems and things in the brain. And so PTSD will benefit from the tools that we use for all of those sorts of things, which can include, obviously we start therapy with rapport building. And if someone's really anxious and distressed, that can take a number of sessions just to help them feel safe with you.
Yeah.
If they don't feel safe in your presence, the brain won't recover. The brain's just going to sit in fight or flight for the whole session and not take in what you're talking about. So we've got to build rapport and make people feel safe. Then you'll normally teach them things to help them get control of that, nervous system response, that fight or flight stress response. So that's where you hear things like, mindfulness, breathing strategies, or relaxation tools, those types of things. And in all those other disorders, we might look at cognitive behavior therapy or acceptance and commitment therapy and those sorts of things and address how to deal with difficult emotions, how to manage unhelpful thinking that contributes to these sort of conditions maintaining themselves. But with post-traumatic stress disorder, I guess there's the added element of you normally will do some trauma-focused therapy, which is going quite deep into, the theory. But the current accepted theory in psychology is that a trauma memory is either misfiled or hasn't been filed by the brain properly, that it's sort of it's being stored in the working memory and short-term memory systems instead of being stored out in the long-term memory system. And in that short-term system, it hasn't been able to be divorced from the emotional content and fear response that was part of it. And so while it stays there, it continues to trigger the fight and flight system as if we're back there in that trauma. And so trauma-focused therapies are aimed at helping to get that memory to move or process into the long-term memory stores. And so there's lots of different ways you can do that. I guess the one that you might have heard more about would be something called eye movement desensitization and reprocessing. Phoenix, Australia was sort of endorsed by a number of medical bodies as providing the guidelines for the best practice treatment of post-traumatic stress disorder, and EMDRs in their guidelines as, best practice therapy for post-traumatic stress disorder. So that's what it falls in the type of therapy that we call somatic therapy. So they've been around for a long time, but they sort of disappeared with a wave of when cognitive behavior therapy became really popular.
Yes.
And now these more therapies that integrate the body and sort of look at how the body can store trauma and how it can help to process trauma has been sort of much more prominent. So in eye movement, EMDR, we call it for short, we actually move the eyes in a particular way, which sort of helps to put the brain into a, I guess this is all, very broad strokes overview here. If there's any AIP, which is the theory of why EMDR works, if there's any specialists, they might say I'm not doing a great
all we want is a broad overview.
A broad overview. Yes. But the aim of that is, that we put the brain into a similar state that it's in during REM sleep, because in REM sleep, your eyes move backwards and forwards quite fast behind the eyelids. So we're sort of putting the brain into a particular state where it's receptive to processing of trauma.
Yeah.
And then we guide the client through that processing of that trauma.
That's amazing. That's so great to know. It's something that I didn't know. And I've learned something today, and I'm sure, all listeners have learned something today where that's, like we don't really get to understand the actual strategies behind what you do. It's, we just know, they're talking about the trauma and you're getting to practice mindfulness, meditation, things like that. But to understand the theory behind it really, gives us a good insight and the value that you provide in those sessions as well. So I guess, leading on to that, what are some of the main challenges that you've had in the past with these workers' comp clients? You mentioned, obviously the various stakeholders involved and the stress with that. But is there any particular challenges with these workers' comp clients compared to private paying patients, for example?
Patients. I definitely think there is, and I think there's probably research that supports that. I'd say the first one is really that engagement of different stakeholders, and that sense that it's like once we're absorbed in a personal injury scheme, and I would say this also for, income protection, life insurance sort of situations as well. Sometimes when we're absorbed into those schemes, we start to feel quite out of control. Like it's sort of, you're being told to go here and do this and see this person. And you can't see that person because they're not zero accredited, even though you want to go there, and you can't, and so people start sort of taking a bit of a back seat and might not always, take the initiative in the way that they would around accessing treatment, but also in their recovery. They might take a back seat and let other people decide, or let their workplace decide what's right for them when they go back. And of course the workplace has a stake, but people sometimes struggle to have a voice, about saying, well, look, I'm really worried about doing this duty when I go back because of X. They sometimes sort of just stop advocating for themselves because the system sort of is so disempowering, really. And it's not a criticism of, this system's just so terrible. It's just the process. Like, it's doesn't have to be any particular person doing anything wrong, but just the way personal injury works is that it can be disempowering. So that's certainly one challenge. As we said before, sometimes, various stakeholders might not always be particularly helpful. There's been times in my career where, I hate to say it, where I've had someone almost ready to return to work and a manager has just, handled things really poorly, or someone's progressing, but the approach by the, insurance case manager was quite harassing, which then reminded them of the bullying and triggered off symptoms, and we're back to, square one. So again, that's not to say anyone there had bad intention, but the reality, Ryan, is most people don't have a great understanding of mental health conditions.
Yes.
And so sometimes we're actually hampered by people refusing to engage with the injured worker because they're scared of triggering them. But that lack of engagement is actually perceived as a lack of support. So it's not always done with bad intention, but a lack of knowledge and a lack of mental health literacy really contributes to people feeling not supported. So that's sort of one big part of it.
The amount of times we hear an injured worker say their employer hasn't contacted them, and how that makes them feel, and that happens all too often in the workers' comp space. It just pick up the phone if you're an employer, pick up your phone, call your worker, check in on them. No harm.
100%, and be guided by them. If they say they don't want to hear from you, then of course, but never assume that they don't, or assume that will be distressing for them. I definitely think that's right what you've said there. And then, there is secondary gain issues in these systems as well, which I remember a long time ago, sort of feeling like the perception was everyone's malingering, everyone's faking, this sort of like belief that seemed to be ingrained in the system. And I can honestly say, I have a client who tells me I'm too nice, and think in terms of rainbows, and maybe I am, but when you get to know people in this scheme, I can count on one hand in 15 years the people that I think were genuinely just in it to try to get some sort of financial outcome and were not actually distressed by what was going on for them. But the reality does become that getting well reduces the amount of money we receive. So there's kind of this, disincentive to get well. And so, for some of my clients in the Medicare system, if they need to work for money, sometimes they are more eager to put in place strategies, and those sorts of things. That's certainly not true for everybody. But sometimes we see people after a work injury damages claim sort of, settles, and they recover really quickly, and that people go, oh, they were faking. I said, well, no, the system pressures were removed, but also there's now a lot of incentive to get better, kind of thing. And so they might be more dedicated to doing their exercise. They might be more dedicated to that, stuff because, there's an increased incentive to do it. So
yes, that makes perfect sense. Yeah.
And it's not a conscious choice. I want to keep getting the money, so I'm not going to do my things. but there's not that added motivation of, oh gosh, if I want to put food on the table, I've got to get my mood sorted. So I'm going to, make it as the biggest priority that there is, kind of things. So.
Yeah, exactly right. Yeah, you've highlighted there. It is a complicated system, and it, it does make it a bit more challenging for those workers that are in it. And like I mentioned, one of the main things that the research tells us is that one of the big factors to recovery is self-efficacy and locus of control. That's one area that I feel like the system can improve in, just figuring out ways to promote that. The more in control they feel, their self-efficacy levels, that is the biggest factor, more so than anything else they've found. But it's we take that away from them, then the durations get stretched out a little bit longer. And
I could not agree more. You've hit the nail on the head. It's something we talk about in one of our courses, is that exact locus of control, and the helping people to establish a more internal one, in this system is really, really important. And so, as health professionals, I think, we can do that in little ways, so we can attend a case conference and give our professional feedback on how someone's going to their doctor. Or you can kind of sit in that case conference and say, well, here's my thoughts, but, bring the client into the question. Do you think that's right? Do you agree? What things do you think you've improved on lately? Yes. And even though as the clinician, that information and you can give it, letting your client have that voice and confirm that information and share their side is, a way to bring them into the decision-making and part of the process, I think.
Yeah, exactly right. That's a great point. So just recently I was on the CIRA website, and you can look at their live data around claims, and there's every little bit of data you can look at. But I was looking at it just from a broad perspective, and psych claims are increasing over the last 3 or 4 years. I've chatted with a few people about this as to why. There's a few sort of hypotheses that I've spoken to a few GPs about it, and they've potentially thought, because you think, psych claims are increasing, that means potentially bullying at work is getting worse, or people are being exposed to more dangerous situations, or it could just be more awareness of their entitlements. What are your thoughts on it? Why do you think psych claims are increasing over the last 3 or 4 years?
Yeah, I think I was always told, particularly as well over this last year or two, the more, financial pressures increase and stress happens, then we tend to see an increase in psych claims sort of in personal injury sectors anyway, just because people are under more generalized stress in their life. And so they're then less resilient to handling, whatever the workplace thing. So I think that's certainly part of it. I think COVID tested our resilience in a lot of ways as well. And I think there's a lot of people who were just keeping their head above water in that time. And then as things have settled more and life's gone back to this new, version of normal, they're realizing how, hold on, maybe I'm not coping. So I think that's been part of it as well. But I think there's an increased awareness of, what mental health symptoms are, and a willingness to come forward and seek help sooner, which is awesome.
Yes. I
do think there's a little bit of pathologizing normal human experience that happens a little bit sometimes as well, where a lot of people are, colloquially saying, my anxiety, my PTSD, it's become so accepted that it's almost, no, hold on, that's just a normal, uncomfortable, difficult emotional experience. That's not actually a mood disorder. So I think sometimes people are putting their hands up as I've got a mood disorder when they might be experiencing, discomfort in their life associated with something that's normal, post a breakup, say, let's go, kind of thing, having low mood for 3 months post a romantic breakup is considered normal human experience. Of course, if people aren't getting out of bed and they're self-loathing, and that's not, that might be more indicative of a mental health condition. But so I think we've over-pathologized things a little bit in some circumstances. But I do agree with, what you were saying just there as well about, I think people are more aware of what's not okay at work, bullying and all these psychosocial hazards that we're seeing, burnout, overworking and those sorts of things. So people are putting their hand up a bit more. So that's sort of my take on it. I don't have any research backing that, but I just feel like that's, anecdotally what I'm seeing.
Well, like I said, it's good to have a discussion. If we knew the exact solutions, I'm sure they'd be addressing it, and we wouldn't be getting an increased amount of claims. So it's good to know your view on it. But I guess from an exercise physiologist point of view, Can you tell us a little bit about what you'd be looking for if you were working on the same claim as an exercise physiologist? What would you be looking, for from them, and what would be an ideal sort of, relationship with them look like when treating the same worker?
Yeah, I love working with exercise physiologists as a profession. You guys are just really helpful, positive kind of people I tend to find good to have on the claim. Once my clients engage with an EP, they normally get so much out of it. So, I'm obviously very well aware of the, changes and improvements we see in brain, like growth factors and neurotransmitters and things that come from exercise. So can have a real impact on symptoms. But I also love that you guys sort of help with that translation of, we sit there for an hour and say, okay, I want you to do more. I want you to go out more. I want you to see more people, from an exposure therapy perspective. And then often people come back and say, oh, I didn't feel up to it, so I didn't do it. But you guys sort of are engaged more with people in the community. So I find that really helpful as well, whether it's at your own gym, a public gym, or going for a walk around the block. It's just more embedded in their life rather than sort of coming to us. And you often see them more times than we do in a week or in a fortnight. So I think that's really, really helpful. In terms of the liaison, I'm quite happy to get the reports. I always have a little, skim read and stuff. But I tend to find it helpful, relatively early on to have a discussion. But what I would say is, doing this type of work, I've set up my day to have some gaps to be able to call people back. But a lot of the clinicians I used to work with, they're in a 50-minute session. They have 5 or 10 minutes to write the note, go to the bathroom, then they're into the next one. So they don't have a lot of time for frivolous contact, if that makes sense.
Yes.
So just calling to introduce yourself, I probably wouldn't bother. But calling to say, I've now seen this person a couple of times, or we've met for an initial and this is what we're thinking of doing. Do you have any input? I sort of love being able to give that guidance of, our goal is to get people engaging more in the community. So can we start exercise sessions in one environment but progress towards another? Because that would actually help to support the exposure goals that the psychologist is working on, So sometimes you can do that. I once had a great situation where I worked with an exercise physiologist and we were talking about the mindfulness strategies that the client really found helpful and the challenges they were having with embedding it. And it was really beautiful. The exercise physiologist, on the walk that they would go on would stop up on the cliff top and then they would sit, and they knew that I'd been teaching this mindfulness practice and said, let's do that thing Alana taught you now. Like, let's do it together. And so they, when there is that opportunity to chat and talk, they just can really work in sync so that the level of exposure is the same, I guess.
Yes.
So, if someone's struggling, barely able to leave the house, and the exercise program is forecast to be in the gym, having a chat, that's going to be too much for them, kind of thing. And so both being on the same page is, what is that nice place where it's not too comfortable and it's pushing them outside of their comfort zone, but it's not too far that they'll disengage.
Yes.
So I think we can kind of collaborate on any of those factors that can come up for people. And as I say, I really enjoy getting that support with implementing any symptom management things that the EP is skilled in and feels comfortable doing can be really helpful as well.
Yeah, excellent. I think if you want to take anything away from this episode, then that's it right there. If you're on a claim and the psychologist is on there, 100% get in contact with them, ask what their approach is, work collaboratively, and your approach can complement their approach, and the worker can benefit. If you can't be working in your silos here and working with your approach, and they've got a different approach. So I think we focus on keeping potentially the case manager up to date, or maybe the rehab provider, but other treating parties is just as important, if not more important. So you can obviously complement each other's approach. So.
And I can say, I think psychologists can be very guilty of that as well, operating in their silos. We are used to that in the Medicare system. We often are a silo, you just report back to a very busy GP. So I think they don't always even understand, like if there's someone who only does a little bit of workers' comp, might not even understand the role of an exercise physiologist and what they can bring to the claim, kind of thing. And so being able to introduce what you can do and how you can support and help can be really helpful. I'd probably just suggest though, shooting off an email or something where you say, like, when might there be time for us to have a chat, and booking it into their diary as like at a specific time slot kind of thing, rather than the phone tag that I can imagine EPs are busy people in and out of appointments as well.
Yes.
You can get into this cycle of phone tag where everyone's in an appointment when everyone else rings back. So,
Yes.
book it as a little case conference and chat that way.
Yeah, definitely. So one of the main challenges that we have as exercise physiologists, to give you a bit of insight, so we might see them for an hour a week, maybe for 2 1-hour sessions, maybe 3 1-hour sessions. Spending all that time with them and their psychological claim, they talk a lot to us. So they tell us a lot of things that we might feel a bit uncomfortable about. We don't have those expertise, and it can be quite overwhelming from our point of view. And yeah, I've had many times, many team members come to me, oh, this client just said this to me. Like, I don't know what to do. I don't know what to say to that. Like, that's pretty full on. So I know you've developed a coaching program to help other health professionals to address this, because it is a big problem within exercise physiologists, and something that we are not equipped with. But yeah, can you tell us, how you came to finding that coaching program and a little bit more about that?
Yeah. So Virginia and I sort of were just noticing in this sort of, compensable injury space that we'd be speaking to claims managers who sometimes were crying because of the level of trauma that they just heard from, someone, or finding that person was really angry and they didn't understand why, or avoiding their contact and they didn't understand why. Often, exercise physiologists have a greater understanding of mental health sort of than that sort of situation where they really had nothing. But we decided, let's see how we can get to the people who are supporting those experiencing mental health and try to remove, we said earlier in the episode, some of the barriers that come from a lack of mental health literacy. So let's start to, work on those. And I think when we started working on that, we realized, oh, hold on, there's a lot of allied health professionals that work with us in this system who say, we don't get given as much training as you'd think in mental health. And we are hearing things that are impacting on us and our well-being, or we don't know, are we responding in the right way? Exactly like you said. And so we sort of thought, okay, we need to give people sort of accidental counselling skills. So we did some as a training just for a little while with some companies and that type of thing. And then we went, we've got to make this accessible. So we've actually developed an e-learning program that is complemented by coaching sessions. So it's all video learning that you can do on your phone. And we cover off sort of 3 main areas. And the first one is mental health literacy. So some of those things we were just talking about with trauma, understanding what are the symptoms of each of the common sort of conditions that we were talking about earlier. What's going on at a brain level in those diagnoses, so that we understand, like, why is this person avoiding my phone call? Why are they getting angry? How does that relate to their illness? Those sorts of things. And in that first component, we talk about those basics of communicating with someone who's in a heightened fight or flight, response most of the time, because that is the case. If people are mentally unwell, they're fight or flight system, their limbic system is kind of hijacking the brain all the time, and their rational brain isn't always as accessible to them as it normally is. So how do we use communication tools, empathy, trust building, validation to help someone feel safe? Yeah. And to also, like, as you say, sometimes I think our greatest thing is when we don't know, we think we have to do more than we have to. So I've got to solve this. I've got to know how to respond to this major thing. Well, we actually talk about sometimes it's the basics of that response, an empathic sort of response that can help that person feel heard, but you don't have to solve anything. So we talk about all of those sorts of things in it. Our second component area is around more complex presentations. So when there is significant risk of harm, or there's people who are displaying really complex engagement behaviors where they're getting very aggressive or angry and those sorts of things. And we talk about why does that happen, and again, what you might be able to do to help de-escalate some of those situations, or to work more effectively with that person, because insight's everything, right, Ryan? Yes. Once you understand where someone's coming from, you can intuitively figure out how to respond. But if you don't know why they're doing what they're doing,
yes,
you can't figure that out. So we go over a bit of that theory around, deeply held belief systems that people have, and why that might guide how they present to you and the way they interact with you, or might be mistrustful of you, those sorts of things.
Yeah.
And then our last sort of component is all around how do you look after yourself, because there is that reality that hearing sad stuff impacts on our mental health, hearing traumas all the time. we did some training recently with the Children's Hospital, and we're all sort of talking about, as people who see the worst things that happen to children, how hypervigilant you come about, their kids are in car seats till they're 12, like kind of thing, because they're worried about road trauma. So these stories do sit in our heads and they do affect us emotionally. So being able to look after ourselves and minimize any risk of burnout and compassion fatigue is really important when you do this sort of work. So we went big. We decided we were going to try to tackle everything.
Yeah.
And it might be ambitious, but we really wanted to help our fellow supporters, and a bit of a psychology, introduction to help get people,
No, you've absolutely found a gap in the market. It's absolutely what's needed, and I think it'll only go from strength to strength as more and more people see the value in it, and word of mouth gets around. So how can listeners find more about this coaching program?
Yeah. At the moment, it's advertised on our website as an organizational program. However, in 2024, we are aiming to launch to individual, exercise physiologists, allied health professionals who might want to engage in the training and coaching on there as an individual instead of as a group. And so on, if you go to avenue.com.au, but it's spelled AVINUE, not the traditional spelling, .com.au. On the work with us page, if you scroll towards the bottom, there's a sort of register your interest for individuals who want to find out when we actually are available for the one-on-one coaching programs. That's there. And otherwise, I'm on LinkedIn just under Alana Roberts, probably as Sana Psychology and Avenue Coaching and Training. Trying to remember, but I can certainly give you the link for the show notes or whatever, and people are more than welcome to connect with me on there and send us a message if they're interested in hearing more. So
excellent. I'll put all those in the show notes for the listeners to access and hopefully reach out and take advantage of. But that's all I've got time for today, Alana. It's been an absolute pleasure to chat with you. I learned so much personally. Thank you so much for sharing. It's I got a lot out of it, and I'm sure the listeners did as well.
Thank you so much for having me on. It's really
no worries at all. Excellent. All right. Bye for now. We'll speak to you next time.
Thanks, Ryan.